Hello and good morning or afternoon. My name is Kim Lee and I am an internal medicine PGY3 at Baylor Scott & White in Round Rock. Today I will be presenting my QI project, reducing the use of supplemental oxygen in acutely ill patients. When we think of someone who's acutely ill, it's not uncommon to picture them with some sort of oxygen, whether it be through nasal cannula or an open oxygen mask. We noticed this on rounds, and the question we asked ourselves was whether or not the oxygen was necessary, and if it wasn't necessary, was it harmful? Hyperoxia does have harmful effects, such as obstructive atelectasis, accentuation of pre-existing hypercapnia, especially in patients with OSA, OHS, or COPD, extrapulmonary toxicity, such as decreased cardiac output or local coronary vasoconstriction, decreased mobility in hospitalized patients, oxidative stress, but most importantly, it's been shown that hyperoxia can increase mortality for acutely ill patients and also post-op patients with sepsis. The problem that we identified was that between September 2nd and November 12th, the overuse of supplemental oxygen accounted for 19.8% of the total use of oxygen on the third floor med-surg unit, and our goal was to decrease this percentage to less than 5%. Our method of data collection was collected from the Vitals tab on Epic, and it was all manual. Oxygen use was classified as appropriate or inappropriate, and patients with no documentation of supplemental oxygen or room air were not included in the data set. An example of inappropriate would be if the patient was on room air and then started on oxygen with no documentation of a desaturation or event during the day that justified the initiation of the oxygen. Something that was considered appropriate was if a patient had COPD, was admitted for another reason, and it was on their baseline liters that they always use at home. That was considered appropriate. Our approach was a multi-pronged approach, and it revolved around the creation of a flyer. The flyer documented oxygen saturation goals, and these goals were taken from the British Medical Journal article released in 2018, but we also got it cleared with the pulmonologist involved in our project, Dr. Perkins. We placed the flyers at the oxygen flow meters on the rooms in the third floor med-surg. We also attached the flyer to weekly staff emails to the third floor unit. We placed the flyers on bulletin boards at the resident workrooms, the respiratory therapist workrooms, and the nursing workstations. And then we also presented our project at nursing shift change huddles. After our implementation, we did note a decrease in the inappropriate use of supplemental oxygen from 19.8% to 9.6%. As you can see in the image to the right, the blue data points, which were 45, represent pre-implementation, and the orange represents post-implementation, and the number of data points was 40. Some of the obstacles we ran into in our project was that the flyers fell off some of the rooms. However, given the fact that it was during the COVID pandemic, we didn't risk exposure of our team to go in and replace the flyers because our project was multi-pronged anyways. Something else to consider would be that the project was taking place during the COVID pandemic, in which there was an increased focus on oxygen saturations. We just aren't sure of which way it affected our project. And also, because of our method of data collection, our data points didn't meet the criteria for statistical analysis. So although we saw a decrease, we don't know if it's significant or not statistically. Moving forward, oxygen is a medical therapy, and similar to telemetry, it should require an order in Epic that is set to expire every 24 to 48 hours so that we can consistently reevaluate whether or not patients need oxygen. Thank you. Have a good day.